Good evening, everybody, and welcome to Fertility Week. Tonight is the second of our webinar series for the week. Fertility Week this year is entitled Meet the Usual Suspects, and it's about the most common causes of infertility in New Zealand. For those of you who don't know, Fertility New Zealand is a registered charity. We've been around for more than 20 years, and we exist to support New Zealanders with fertility issues. We do that by providing information, a lot of which is on our corporate website, support, which is largely through a network of volunteers around the country who run support groups, and advocacy. Tonight's webinar will be a presentation of about 15 to 20 minutes, followed by question and answer. So if you have any questions during the presentation, please type them into the box and they'll be answered at the end. So now I'd like to introduce our speaker for this evening, who is Dr. Greg Phillipson. He is a fertility specialist, currently with Fertility Associates in Christchurch. We're really pleased to have Greg speaking to us about male factor infertility, which is a really important subject. So thank you very much, Doctor, and I'll hand over to you now.
Good evening, and thank you for logging in. I've been asked tonight to talk about male factor fertility, and I'll just take things step by step and hopefully answer some questions at the end of the talk. Male factor fertility has been defined by various organisations, and we could look at it in different ways, but often it does relate to sperm details and how long it might take for someone to achieve a pregnancy. And one of the ways that the World Health Organization defined things was looking at the details within a sperm sample. These numbers originally were defined as averages by looking at many samples, but in the last 5 years it's been changed, not so much to look at what's above and below average, but how long it might take a couple to achieve a pregnancy. And then they determined that if certain factors were above or below that criteria, that's what they would define as normal. If we look at these numbers in terms of the volume of a sperm sample that a man might provide, these are thought to be the numbers at which at least 5 or 10% of the population would achieve a pregnancy within a year. But in fact, we know that if 90% were to get pregnant, those others are still quite possibly going to achieve another pregnancy. It's just how long might they wait. And so it's an arbitrary figure by using the sperm guidelines. In particular, there you can see things like a count of 15 million per mil. That means if someone's got about 20 million sperm, we'd say that's technically normal. Then again, there are some men that have fewer sperm but will still have no fertility delay. There are others that have tens of millions of sperm that may not actually be fertilizing their partner's eggs very well. And the bottom character there is morphology, and that refers to how normal sperm appear down the microscope. And that's why just relying on a sperm count rather than looking at some of the details of sperm quality is thought to be very important. Humans, unfortunately, don't make a lot of healthy, normal sperm. You can see there that if someone's indeed got 5 or 6% of their sperm normal, we would say that that's an acceptable percentage. But realistically, it still doesn't tell us what's within the sperm. We then would say that if we looked at thousands of couples, probably about a third have male factors as the single major cause delaying pregnancy. And yet there are other issues other than just looking at sperm numbers and just these things we can assess in the laboratory. There are obviously issues regarding the way in which the sperm fertilizes the egg and the function of sperm that can only really be properly assessed within the human body, sometimes within procedures like IVF, where we look at how sperm bind to eggs and so forth. moving on to our next slide, unless there's no sperm, there must be an ongoing chance. And that's why this issue of duration, how long a couple have been together, not using contraception, in which they might have become pregnant. And that's where sometimes couples say to me, we've only really been planning to get pregnant in the last year. But if they had indeed stopped using contraception maybe 2 or 3 years ago, then we would really date the onset of fertility from when they last used contraception. And issues such as previous pregnancies can be very important, because sometimes men have quite a fluctuation to their sperm count, but still have had children previously. And that's why just using one test to guide us is probably not enough. And if there's any doubt about a man's sperm count, it's probably best that we ask for at least a second sample and maybe some of the more advanced tests that we talk about and can do in the laboratory. And then to look at any fertility as one person really has some problems. We've always got to take into account the female's partner's health and age. And it means that by taking history both male and female, you can actually elucidate how important the sperm details are. And that's why some couples find that they may have indeed achieved pregnancies when younger. They may have even had very similar findings in terms of sperm details and all those criteria we looked at, still may be having delays now. And that's why I think it's not as simple as just looking at numbers on a page. There are some specific factors within a man's history that can elude us and point to certain issues, but generally we don't find this. And some of the issues are things such as men who, through anatomical reasons, may not actually be ejaculating and providing us specimen. And there are some conditions such as diabetes which can lead to this. Certainly some men that have had surgery, such as prostate surgery or injuries to their anatomy, even things such as spinal injury. Some men may be able to ejaculate, but the sperm may not be actually emitted from the penis. They may in fact end up in the bladder, and in this way we can sometimes recover sperm directly from a urine sample and process it in a sufficient way to be inseminated. Another factor that can be quite important in a man's history is a history of surgery or undescended testes as a child. And it's thought that this can affect the sperm production in an adult. And for that reason, people that have had hernia repairs or problems as a child, having had testis surgery, probably need to do a sperm count sooner than others. And so whereas we might say to some young couples it's not necessary to do a sperm count at their first appointment, I think any man that's had a history of surgery for undescended testis would benefit from a detailed sperm analysis, particularly some of those things that can be done in a fertility laboratory that may not always be available at a local pathology laboratory. Unfortunately, only a few couples in which there are male factor will be able to give an exact answer just by taking a history. And almost always we'll ask the couple to provide at least one sperm sample for analysis. At present in New Zealand, we can't always get the detailed analyses in some smaller centres. We're doing our best to get those samples analysed, and part of the sample may even be transported to a laboratory in one of the main centres for further analysis. Usually your own local doctor should be able to speak about this, but if there are difficulties, it's the sort of thing that presenting to a fertility clinic or a specialist obstetrician gynecologist or even urologist should be able to give more detail if you're having difficulties getting those questions answered. If we look at how we get these answers, the initial sample may have those questions of motility, morphology checked, but more complicated things like anti-sperm antibodies may form after surgery or injury to the testis. Antibodies may slow sperm, and may interfere with its ability to migrate to the fallopian tube. They may also prevent eggs and sperm fertilizing. People talk about sperm being incompatible with their partner's eggs, or issues about immune disease, or a woman maybe being allergic to sperm. These things indeed are very rare, but for those couples that may have an immune factor such as sperm antibodies, it's one of the conditions that is very treatable and normally has a good outcome, but may require things such as laboratory preparation of sperm. FSH is the hormone that controls egg production in men and women, so that the egg in a woman is released once a month. The male sperm is produced every day. But that same hormone, FSH, controls the cell's development. And for that reason, just as we measure a woman's FSH and estrogen level, for men we may measure FSH and testosterone levels. Prolactin is a hormone produced by the pituitary gland, and for both men and women, disorders of the pituitary gland may lead to upset in sperm or egg production. Finally, there are some conditions where men don't produce sperm, and we may only get the answer by doing a test of their chromosome. And those conditions are rare, probably less than 1 in 200 couples. But when those answers are provided, it is still possible to sometimes harvest sperm directly from the testis, or it may be that there are very small numbers of sperm that can be used even for IVF procedures. Usually if there are genetic or chromosome reasons, as well as seeing a fertility specialist, then there'll be a genetic specialist to discuss these issues. The sort of history that you might expect when you see someone at a fertility clinic will often ask the men about their previous sexual history, their onset of puberty, and it's something that may just be part of a questionnaire, but certainly these things are important questions. They'll often be interested to know if someone has previously been in a relationship and had children, or perhaps been in a relationship where contraception wasn't used and no pregnancy occurred, because this could indicate a longer history of fertility delay than what is currently being experienced with their partner. The factors such as environmental toxins are difficult to prove for any one person, but we do know there's definite evidence that men that have been involved with pesticides and exposure to some petrochemicals and toxic agents can certainly upset sperm counts. In some countries where the health and safety rules are not as stringent as they are in New Zealand, some men will be contacting solvents and industrial chemicals with their bare hands on a regular basis, particularly if someone has already got a low sperm count. It's thought that this can damage sperm production even further. Mumps is something that can cause complete and permanent damage to sperm production. Usually, however, it does not. And it really only occurs when men have had mumps that have spread to their testes. And most men would remember that very clearly because it's painful and causes swelling within the scrotum. Other infections, such as chlamydia and sexually transmitted infections, can also be very important. We're lucky in this country that people tend to be treated promptly if they have these infections, but certainly in the past and in third world countries, infections such as gonorrhea and syphilis, which are things we seldom see in New Zealand, can certainly damage sperm production and cause male fertility delay. I've talked already about previous surgery and hernia repairs, and then often the final bit of an examination, or to give information to a couple, will involve some examination of the testes. The reason for this is that sperm production does occur in healthy sized testes. If men have undergone some injury, whether it be a physical injury or something from an illness such as mumps, then the testis may indeed shrink or become quite soft. We're also interested to know if the other anatomical structures within the scrotum are normal. The vas deferens, which is the tube that joins the testis to the rest of the body, and the normal development of the male hair pattern and male characteristics are all things that a doctor would normally be very interested to confirm by examining. This examination normally is not painful and takes just 1 or 2 minutes, but I think it's an important part of a test if someone has got very low sperm numbers or no sperm. If we then try and actually sum up these things and come up with some real answers, at least half the time, even with low sperm numbers, we don't get a clear answer as to why this is occurring. We realise that there are these factors such as abnormalities of the Y chromosome or other chromosomes. There's increasing evidence that men who are overweight may indeed be upsetting sperm production. And for that reason, I think that anyone planning a family, it's good to be at a normal weight, be a non-smoker, and to be careful about the sort of toxic substances that have definitely been shown to influence sperm production. And it's for that reason couples will often be asked about the use of medicines, drugs such as marijuana and other drugs that we think can damage sperm production. Things such as oxidative stress by free radicals refers to the fact that in rapidly dividing cells in our body, those cells require a lot of nutrients and can be damaged. And for that reason, it's thought that men that are heavy smokers or perhaps poorly nourished can damage sperm production. We see a number of men who have had vasectomies, and although it's a very good method of contraception, they may have indeed regretted that decision, and it may be they're with a new partner, or it just might be that their situation has changed with their same partner and wish to look for a method to either overcome vasectomy, such as microsurgery, or to use IVF procedures. As vasectomy is so common in New Zealand, in fact, there are many hundreds of men a year who seek help because of a previous vasectomy. The chance of reversal working actually depends on how long ago it was done and their general health. Environmental toxins decrease sperm numbers. And some of these things that are mentioned here would like to think are very uncommon in New Zealand. Xenoestrogens refers to people who may be exposed to estrogens, perhaps even plant estrogens. We think that soy foods and a very high intake of soy products can in fact have an effect on some men's physiology. But certainly as heavy metals and other chemicals, people working with industrial chemicals need to follow rules and guidelines just as they would their own safety, but also for their fertility. The lucky thing about these toxins is we believe that they are only short-lived effects, and most people, even exposed to quite toxic chemicals, usually will produce normal sperm again in the future. This may not apply to radiation, however. Whereas we think there's some concern about laptops and cell phones at very low levels of radiation, but when people were exposed to radiation in the atomic bomb, Hiroshima, we realized that some men were rendered infertile for a very long time. And the same with radiation therapy for some cancers. When we're talking of heat radiation, we realize that at the extremes, the sperm can be damaged. And for that reason, if men are indeed exposed to electric blankets or very hot temperatures on a regular basis, they may limit their sperm production. Most men with good sperm numbers, this won't matter. But if someone has already got a factor with lower numbers of sperm, then maybe it's just enough to make those issues important. And for that reason, it's worthwhile, I think, being aware of those issues. But in fact, it's not likely that someone will turn around a severe problem by just having less contact with heat or less spa bars or wearing boxer shorts, but it might help a little. The treatments that we use should really be directed to the problem. And the difficulty is we don't get an answer in many men. There are some problems, though, that are very, very treatable. Hormone replacement refers to giving that FSH that we know makes sperm develop, And in the same way we give these injections to women who require eggs to grow, we realise hormone replacement injections can allow sperm to grow for those times that men have got a lack of that hormone. It may be something that has been with that man their whole life, but in fact a lack of FSH can also occur from some unusual causes such as head injuries and car accidents, and can also occur when some men have had tumours of the pituitary gland. I mentioned how weight can be important and alcohol, so we try to focus on those things, particularly if someone is at the extreme. And so it's difficult to say that someone being a little bit overweight makes a difference, but certainly those who are very overweight need to think about this. Donor insemination could really be considered for any man with a very low sperm count. However, obviously in the last 20 years, advice has changed, and we often do not think of using donor sperm if any healthy sperm are present for a couple. But then again, there are some men whom we cannot recover sperm, and donor sperm treatment is very successful, usually offering about the same chance of pregnancy that that woman would achieve with control intercourse. So it may take some months, but the outcomes are very good. In terms of looking at these other treatments, IUI once used to be called just artificial insemination, but it refers to the intrauterine insemination, usually of millions of sperm, to increase the chance of those sperm meeting the egg and hopefully fertilizing. It's done a bit like having a smear taken, but it has to be usually performed on the day that the egg is released, so when a woman ovulates. It means that it may be necessary to do this at a weekend, and usually blood tests and urine tests are provided to coordinate which day ovulation is occurring. The male partner would provide a sperm sample that day, although in some instances sperm have been frozen, perhaps if someone is unable to attend the clinic, and obviously that's the same method that we use for donor sperm treatments. These next two things refer to very special treatments that we use within the IVF laboratory. ICSI stands for the intracytoplasmic sperm injection process. It's where a single sperm can fertilize an egg with the use of a very small syringe to place that sperm inside the egg. It was developed in the early 1990s, and it has really transformed the management of male factor low sperm count problems. And there are now millions of children born with this process. The frustration is, however, that it does require IVF procedures in which the woman would normally undergo injections for a few weeks to have eggs collected. And even though an embryo forms, the chance of it developing into a pregnancy relates to the health of the woman and her age. And for that reason, unfortunately, some people may get satisfactory appearing embryos but still not result in a pregnancy. Currently in New Zealand, for women under the age of 35, we would probably expect about a 50% chance of pregnancy with an embryo when it's transferred. But we realise that by the time that someone is 40, that implantation rate for one embryo is probably about 30%. These new methods mentioned below are really extra methods that may assist the scientists choose sperm to fertilize eggs, and they refer to the way in which sperm may be identified either by binding together on special cellular plates or by looking at them down the microscope to try and choose the best possible sperm when we're looking at them at very high magnification. Both of these methods have got some merit, but they're things that are still under evaluation, whereas IUI have definitely been proven for many years. I think we'll hear more about PIXI and INSI, but it's debatable to what extent they may help any one couple. So here's some advice perhaps that what could one do prior to ever seeing a specialist or seeing their doctor. I've mentioned the things about temperature and the effects of possible other chemicals. Medication is something that usually is well explained by the doctor that prescribes it. But there are times when some medicines can work together, and I think on that basis, it's worthwhile asking whoever's prescribing them, could there be a relationship? And there are certainly some things that act on the hormone system, and even things that appear to be assisting may in fact not be. And for that reason, men taking testosterone supplements or anything that's got a steroid within it needs to be carefully considered, as it may in fact be making matters worse rather than helping. Stress is something that may work in various ways. We realize that when a woman is experiencing terrible stress such as bereavement or business problems or emotional problems with a partner, they may stop ovulating. And men may indeed stop producing sperm in those circumstances as well. But because sperm take about 6 to 8 weeks to grow, it may not be as immediate, and it may be over time that stress affects sperm counts. In terms of age, sperm count will decline because men do have lower levels of testosterone as they get older. We think this does relate to sperm health. We're also concerned that if someone is aged above a certain level, perhaps we'll say 40, there may be an increased risk of miscarriage, and it may take longer to achieve pregnancy, even though the sperm counts appear as good as they were. In terms of the frequency of sex, the general advice has been that if someone is having intercourse 2 or 3 times a week near their fertile time, they should achieve pregnancy. Why we come up with those suggestions is that sperm may live for 3 or 4 days within the woman's body, but if someone has not ejaculated for some time, it appears that the quality of the sperm may suffer. And for that reason, those couples that would perhaps plan to have intercourse on their fertile day may in fact do better if they were to regard it as a fertile window of opportunity rather than just that day of ovulation. Also, there are some situations where men, if they have a very low sperm count, may not actually produce a good number of sperm if they were to have intercourse each day or more frequently. And so in that regard, a sperm count may give information as to how often people should indeed have intercourse. Exercise is something that we encourage many people to maintain for lots of reasons, not just their weight, but because of their general well-being and general health. At the extremes, so we'd say if someone is doing more than 8 to 10 hours a week, sometimes it can affect that FSH effect fertility. But if a sperm count is satisfactory and a man is exercising at these levels, I don't think they need to reduce exercise with all else as well. So overall, a lot of the advice that we give to anyone to maintain a healthy lifestyle also applies to sperm. Some of the nutrients that get mentioned are agents that work within cells that may indeed have effects, but it's very difficult to show in humans to what extent. I think if men are deficient in some of these nutrients, then their first step is to have a balanced diet. And most nutritionists would advise people to be eating fresh fruit and vegetables and eat meat or other sources of protein if they're vegetarian. And in my experience, most vegetarians are very aware of the need to have a varied diet rather than to rely just on one particular source of protein. Briefly, it describes here what these agents are, and all of these have been shown to help in sperm production. Zinc and folic acid and vitamin B12 have often, and along with selenium, are often contained in vitamin supplements for men. And although there are several on the market, such as Menavit, Vitamins, and I think Thompson's also has a male product, I don't think you can really say that one is particularly better than the other. Menavit has been tested and shown to have some benefit in IVF programs, but I think for couples who are not on IVF, my advice about having a varied diet and perhaps taking a supplement of any sort may be useful. Essential fatty acids are important for anyone, and it is true that if people are not eating a balanced diet including fatty acids, a lot of our body's cells may not be at full efficiency. The dietary guidelines really cover what I've just said about these supplements, but also eating such as proteins and to mind carbohydrates, particularly if someone is overweight. My thoughts are that although organic foods may indeed be a healthy diet, it is difficult to show a direct relationship to some of these issues for any one individual. And it's good general advice what you're given there. Those topics are something that are all matters of research. I'm very happy to answer questions about these things and realise that some of them can't easily be answered. But hopefully that's given some background as to how we think about male fertility and why we submit people to some of the